Hello, everyone. I'm Brent Christopher, president of Children's Medical Center Foundation. We are the fundraising arm of the academic pediatric healthcare system here in North Texas, Children's Health. Welcome to the Children's Health virtual spotlight today on pediatric mental health, a growing crisis for our children. You know, mental health continues to be one of the most pressing and complex challenges in pediatric healthcare today. Obviously, none of us could have predicted what the last year was going to hold, and we still can't predict what may be ahead of us as we continue to work through the pandemic and what life in the pandemic is like now here at the 1-year mark. But what you can continue to count on is the unwavering commitment of our staff, our frontline heroes at Children's Health, who are providing the best care for children and families in our community every single day. You know, childhood illnesses don't necessarily take a break just because the coronavirus pandemic is here. Kids are still facing battles with cancer, with heart disease, with everyday things like broken bones, with complicated issues like mental health. And we're still there helping those kids and their families. And we're on the front lines of virtual care too, including telehealth and telebehavioral health. In fact, we've got one of our leading telemedicine specialist at Children's Health who's going to be with us on the panel today, and you'll be hearing from her very shortly. So while the need to address pediatric mental health has always been important, there's no question that the added stress, the added isolation of COVID-19 has put a spotlight on the struggles that many kids and families are dealing with around issues like anxiety and depression. And they're top of mind for all of us now more than ever. As we talk about this topic today, it's probably good to start with some context, at least, and take a moment to hear the story of one of our patients. We've got the story of a young woman named Lily who was treated at Children's Health, and we're glad to be able to share this story with you as we start today's conversation.
A graduate says she owes her life to Children's Hospital.
She was contemplating suicide, but a one-of-a-kind program helped her through those dark thoughts. Here's Tiffany Liu.
So excited. Oh, I'm so excited.
Graduating high school is a big deal.
I'm gonna be like, woohoo!
Lily Allen is going to college for dance and choreography.
It's new and exciting, and it's fun again.
4 years ago, she never thought this day would come. Lily faces depression and anxiety, and the bullying wouldn't stop.
It just turned into, well, I might as well, commit suicide.
Life to her wasn't worth living. Lily left a note.
But I was just apologizing for all of the things that I had done. I apologized to my family and to my brother and to my friends for what I was gonna do.
Her mom didn't know what she would find behind the bedroom door.
She's my Lily. She means the world to me.
Her daughter was alive, taken to the hospital right away.
At that point, you're just like, I'll do whatever I need to do. Thank goodness everything's fine.
Lily checked into an intensive program at Children's Health called SPARK, Suicide Prevention and Resilience in Children.
It was amazing. It did wonders for her as well as the families.
Learning day by day, life is worth living.
I want to be a rock for people.
She now speaks out and dances for mental health. At Booker T. Washington High School through Will Dance for Change, she's raised more than $4,000 for SPARK.
There will always be someone behind you.
Her goal is to help other teens through suicidal thoughts as she continues to heal herself.
It's like you don't see yourself graduating high school when you're 15 in your bed wanting to commit suicide.
You see, graduating high school is a big deal.
I haven't thought about self-harming or suicidal thoughts in 2 to 3 years. So it's been great.
In Frisco,
yeah.
I'm Tiffany Liu.
Lily is an incredibly courageous young woman, and I can share with you that she did graduate from Booker T, and she's gone on to be a college student. We're really glad that she was willing to let us share her story as an inspiration to others, and just as context today, again, to understand the range of the things that kids and families are facing in the community, certainly during, again, this pandemic more than ever. So let's think about this in an overall spectrum, maybe about the range of mental health crises that families and kids are dealing with. Lily's anxiety and depression obviously reached a critical point that resulted in her attempting suicide. And in that case, we've got some incredible resources at the hospital for those emergency and severe situations when kids reach that kind of breaking point. We've also got some of the best and most innovative related outpatient programs in the country. You heard the SPARK program referenced in that WFAA story, the Suicide Prevention and Resilience in Children program. That program, again, is recognized around the country as one of the best that there is. Those resources, though, are available for kids really at that most critical crisis moment. And today we want to focus on not so much what happens at the hospital, as much as on how to reach kids early, how to reach kids where they live, how to reach kids where they go to school, so that hopefully many fewer of them ever hit that breaking point. And fewer of them are required to be rushed to the emergency room or to have to face an inpatient stay at the hospital or some of these more significant treatment options. So these experts who are with us are going to talk us through what that whole spectrum of care looks like and how some of the early intervention strategies and research into what may be driving mental health issues in kids can inform the way that we approach this topic going forward and give kids and families hope. As we get started, I'll make a couple of quick notes as you're participating in this program today. There will be a question and answer session at the end, and you likely may have some questions along the way. So please feel free to submit them to the text number 214-725-7387. Again, that's 214-725-7387. You see it now at the bottom of your screen. That's going to be shared throughout the program, and we'll collect those questions for the Q&A part that will be coming up later with our panel. Also, if you or someone that you know is dealing with a mental health need, we're going to have a list of resources available for you at the end of this program as well. So please do stay tuned for that, and we'll share that information with you after we work through some of this panel discussion today. Let me begin now by introducing the folks who are with us. It's a pleasure first to introduce Julie Hall-Barrow, my colleague here at Children's Health. She is our Senior Vice President for Network Development and Innovation, spearheading our development and implementation of innovative care, including new approaches to diagnosing and treating pediatric mental illness in our community. She oversees the Children's Healthcare Network, which is a collaborative network of health providers that includes both physicians that are employed by Children's and community-based physicians. She joined Children's Health in 2015, and she's guided our system's strategic use of technology to extend and expand access to care beyond just the walls of the hospital. She'll be talking about that more today. Julie's a well-known expert in the field of telemedicine, and she currently oversees one of the largest and fastest telemedicine programs right here at Children's Health. Next to her on the screen there, you see Andy Keller, PhD. Dr. Keller is the Chief Executive Officer and President and the Linda Perryman Evans Presidential Chair at the Meadows Mental Health Policy Institute. Andy is a licensed psychologist with more than 20 years of experience in behavioral health policy, financing, and best practices. He also is one of the foremost experts on those topics in the country. His work has centered on helping state and local healthcare systems implement evidence-based and innovative care, as well as helping state and local governments develop the regulatory and financial frameworks to support them, a critical piece and a very complicated and difficult part of the overall system. He'll be talking about that a little bit more in our discussion today. Andy, thank you for being with us. And then Dr. Madhukar Trivedi, professor of psychiatry and chief of the Division of Mood Disorders and a founding director of the Center for Depression Research and Clinical Care at UT Southwestern Medical Center. Dr. Trivedi holds the Betty Jo Hay Distinguished Chair in Mental Health and the Julie Hirsch Chair for Depression Research and Clinical Care. Dr. Trivedi is certified by the American Board of Psychiatry and Neurology. He also is a national and really internationally recognized translational researcher, focusing now on developing and validating the genetic signs of depression, the genetic markers of depression, particularly working with young people. Dr. Trivedi has authored more than 500 peer-reviewed articles and chapters about the diagnosis and treatment of mood disorders. Welcome to all three of you. We're so glad that you could be with us for this conversation today. Let's get started, jumping right in to really talk about the overall landscape that kids and parents are trying to navigate right now when it comes to dealing with mental health challenges. And certainly we know that anxiety and depression are top of mind for so many of those kids. And their parents, it's a challenge for us as adults. There's some unique challenges that kids are facing. And maybe, Dr. Keller, I'm going to toss this to you first to just help us get a picture of what the overall mental health landscape for kids looks like in the United States today.
Yeah, absolutely, Brent. First of all, it's great to be here. We're very lucky to have Children's Health and UT Southwestern here in North Texas, and it's great to be here with my colleagues. You know, I mean, there's some hard news. I mean, it's sad. There's a situation, and it's gotten worse under COVID. I mean, before COVID, death from suicide was the second leading cause of death among American children, and those rates were going up, and they're going up across the board. I mean, some of the very disturbing statistics we saw in the most recent data that were released, which were pre-COVID, were African American youth, young men, older adolescents and young men, increasing rates. So it's really affecting every subgroup of our community, everybody, and and the rates are going up. And under COVID, you know, we're still detecting. One thing about rates of death from suicide is it takes a long time for those data to be sorted through, and some of that's understandable because we want to make sure we're not over reporting, but some of that is just because we've not really, I think, paid sufficient attention. But there's some very concerning signs. The CDC tracks weekly rates of depression and anxiety in the overall population. The most recent ones have shown 4 out of 10 Americans with increased rates, clinical rates of depression or anxiety, which is 4 times the rate that it was pre-COVID. We're seeing large increases in the number of young people, both children ages 5 to 11 going to emergency rooms for mental health related visits, up almost 25%, almost a third higher among adolescents. So it's a very difficult, challenging thing. You know, I don't want to just end on that, though. I mean, the good news is we've learned some things under COVID. We've learned that we can quickly pivot to some of the strategies that you have pioneered here at Children's, and Julie in particular has around telehealth. We have increasing information about what can work around early intervention, but the landscape going in is one that's very serious, and it's one where far too many people have unmet needs.
So as we start talking about that landscape, Julie, maybe it would be helpful if you could help give us a picture of what the range of resources and needs look like. When a lot of us think about mental health issues that our kids are facing, we're kind of stuck. You know, we don't know how to assess them and sort them out. We don't know where to go for help, and we don't know what the real range of those resources is. You think of kids and families that show up in the emergency room and that need care in the hospital, and yet we also know that there have to be a lot of other resources and options that are available too, but we don't know how to make sense of all that. Talk us through what that spectrum looks like.
Sure. And thank you so much, Brent. And of course, Andy and Dr. Trivedi, just incredible teamwork that we have between all of our great institutions. And so as we just spoke about, the emergent need for care when there is that breaking point really is those smallest number of individuals, although that number is growing. When we begin to think about the continuum of care that these children need or should be accessing care, is many times that's not happening. So I'd love to share with you a little bit, and hopefully this graphic will be explanatory about some of the work happening at Children's Health here in Dallas and Plano. So as we spoke, the inpatient, the most severe, is really that hospital emergency room and psychiatry unit that we have at Children's. Although we have a psychiatry unit, we absolutely do not have enough beds for all children in North Texas who absolutely need that type of service. We also have a pretty incredible eating disorders inpatient program, and it too serves a number of patients in North Texas. And we continue to see that that's a program that has to have both inpatient and intensive outpatient opportunities. One of the more innovative opportunities that we've had is really how do we create more partnerships, more affiliations in the community, and ensure that we're providing the utmost resources at Children's Health to make them the best community providers. And so in our Children's Healthcare Network, we've added both Perimeter, an inpatient facility for children in Dallas, and Haven, which is an inpatient facility in Frisco. And again, why that's so important is when those children are in our emergency room and they absolutely need an inpatient stay and Children's is full, we have direct access to be able to get those children into one of our affiliated programs and get them the care that they need quicker. And so I think that's really important to understand, is that once we identify a need, the time to treatment is just like any other health emergency. Quickly getting them to a treatment improves the outcome overall for those patients, and more importantly, those patients' families. And so really just moving now down the continuum, if you're looking in the middle, there's a number of outpatient programs that Children's provides, specialty clinics such as autism, our eating disorders program that's outpatient as well, psychiatry in general. We also have a unique program. It's our substance abuse program, which combines both behavioral health and substance abuse to really help those children who are suffering from more than one focus in their behavioral health needs. And last but not least, you heard about the suicide prevention and recovery program. Incredibly important. And again, how we get children access into those quicker, sooner is going to improve those outcomes. But I think what we're really excited to talk about today is really that less severe. How are we really engaging in our community? How are we getting children access at a much closer area to them? And how are we doing that in a way that's easy for parents and families to access? And I think that's incredibly good. And Andy spoke a little bit to how we have launched here at Children's several years ago, what we called school telemedicine. It was really those low acuity events that happened on the medical side, ear, nose, and throat rashes, and how we were able to do that. And we really were able to leverage that network of telemedicine to begin to address behavioral health, which was an overwhelming request from ISDs across North Texas. And I'll have to say, we spend a lot of time educating those across the country about how we've built this network. And working with Andy, it was recognized as a really great model for our whole state and was successful in getting funded. But what it does, it allows both counselors and teachers to say, this child is changed. Something's different. We've noticed this, or mom has said, hey, my child has anxiety, or we feel like they're not coping well. It quickly gives them access in a place that's safe, that's secure, and we're able to actually work with those children and determine if we can give them the skills and resources right then, and many of them do. And if they need a higher level of care, we are then case managing those to community providers and the individuals at the right level of expertise. And I think that's critical. We've also begun to embed with pediatricians in our integrated behavioral health. Our pediatricians in our community are the front line. They are the ones who really see these children, and in their well child visits are identifying we've got to address both physical and mental health. And we have some unique opportunities where we want to, again, arm our pediatricians with resources, training, and some exciting things coming in documentation and billing that we're working on with Andy and team, but really arming them with those things that can really address what we're calling the lowest level of acuity, and reaching that at an early point that allows this child then to carry those resources with them throughout their adolescence, young adulthood, and will provide them the skill set to hopefully reduce the amount of emergent going all the way down that arrow of continuum. We want to be sure that we're providing those right resources at the right time, at the right place, so that the emergent need isn't there, and that emergent need is not overwhelmed with low acuity type of visits that allows for, when they do occur, quick access, movement into the right layers. So that we're excited about that.
So let's double down on that maybe, and I'm going to sound a little Barney Fife-ish here to say what you're describing is sort of a nip it in the bud type strategy around that early intervention. Before we get into that and understanding that more, Dr. Trivedi, talk to us a little bit about the warning signs that we ought to all be looking for. I think that's oftentimes one of the most confusing, intimidating, scary thing, certainly to parents and family members. What do I need to be looking for, and what are the signs that my child could have a mental health issue that needs to be addressed? I don't want to miss it. I don't want to overreact. How do I know how to sort through all that?
So I think that two or three things, and I think, Julie, you outlined the major issue is that we tend to, as a society, always focus on the most severe and the most emergent issues, which we need to take care of. Some kid is suicidal, we should. I think we have to change the vocabulary and start early, and should be universally recognized. And so that's where these early signs come in. If your teenager is not sleeping well or has some change in their behavior, please do not write it off as teens being teens. That behavior They're changing their school environment. They're changing the friend circle. They were very outgoing. Now they are fewer friends, or they were very isolated. They start going out more. Their sleep changes, if their appetite changes, if they become more irritable, if their grades start being affected, if any of the teachers call you that he is not or she is not paying enough attention, are all signs that really mean that you've got to try to get the consultation. And that is where I think that what Children's is doing, what Andy and the group have really argued for, and what my work has been, is that we have to change this from all the discussion about access. Do we have enough beds? Do we have enough psychiatrists? And make it a triage issue. Go where people live, go where teens are in schools, and start screening regularly. You should not think of mental health as something that happens only for some people. This is a very common condition. I tend to do this in large groups and say, how many of you have raised your hand if anybody in your family have had depression, anxiety in your family? And a lot of hands go up, not surprisingly. And I tell the others who have not raised their hands is because nobody has told you that there is depression, anxiety in your family, because we don't do screening. So I think that the answer to this is any change in behavior, any change in their interpersonal interaction with family, friends, and sleep, appetite, concentration, school performance happens, get a consultation. Go to a pediatrician, go to a counselor, go and find somebody who will do an assessment, because that is the only way we can stop all this. We do not reduce colon cancer by treating people with stage 4 colon cancer. We do it by doing colonoscopies regularly. We have not done that, and I think I'm so excited with what Children's is doing, but how we are partnering through UT Southwestern and the work of Meadows that really enhances this change in vocabulary. And one final word, and that I don't want to toot our horn, but I think that this kind of collaboration between what Julie, you're doing with schools, et cetera, with what child psychiatry and we are doing in UT Southwestern, and what Andy is doing as one group, is rare in the country, and maybe Andy can comment on it. But this kind of collaboration across disciplines and across interest groups is rarity. So the only part of your diagram, Julie, that I would add is one more layer, and that is the community needs to demand this. We have to get the community wanting it. We do colonoscopies and mammograms so much because the society demands it. And I think routine screening, routine diagnosis, and routine treatment is essential. And one final word, and then I'll shut up, Brent. I think we should not get depressed about talking about depression and anxiety. The treatments we have available, when you do it at the right time, at the right place, can transform lives and people can get better. And Lily's example is a good example. I'm so glad you showed that. So I think these are exciting times. We obviously have more research to do, but we're doing more research on trying to find better antihypertensive medications 100 years after we got antihypertensive. So that'll happen. But I think this is exciting time for the North Texas area. And thank you for leading this effort, Julie.
Well, please don't make that your last word, because we are counting on you to continue participating in this conversation. There's a lot more to talk about. But to the points that you raised, I think for a lot of parents, they think, I still don't know exactly where to go. So you tell me not to be afraid to address the signs that may be more evident around my house that my child's got a mental health issue. The idea of going to a specialist seems scary. I don't know how to find one of those. That seems intimidating. I'm worried about what may be a stigma for my child. I'm worried about raising my hand. The person I would maybe most normally go to for a health issue is my pediatrician. And we don't normally, talk about the mental health needs of my child when I'm going in for an annual physical or taking my child for routine care. What does this mean at a practical level for how we can do things differently, maybe here in North Texas, and what could even be a role model for others elsewhere around the state or around the country?
I think there are very easy screening tools. We need to develop partnerships with pediatric practices and make them arm them with tools necessary to do this. And Andy can talk more about it.
Yeah, so I know Children's is working right now closely with the Meadows Mental Health Policy Institute around some support for other pediatricians and care providers in the community who don't wear a Children's Health name badge. They're not necessarily on the payroll at Children's Health. This is sort of an all call, right, across the community. What does that approach involve? Maybe, Julie, I'll toss it to you first, and then Andy, if you'll chime in and let the two of you talk about those efforts.
Yeah, I think the first part is giving those pediatricians the tools. So we recently launched a monthly series. It's just like we're doing today, that allows pediatricians to join in and learn and actually share cases about what's going on in their practices. Here's what's happening with this patient, and how can you help me kind of go through and give this child the best experience in my office? And if not in my office, where can we collaborate and get this child to? And I think that's so important. I think the other thing we're doing is we're by their side in terms of integrated behavioral health. Many times there are mental health or behavioral health that arise because they are screening well. I think Dr. Trivedi would say not all have screening in them, but we have a lot that are. And so when they identify something, we partner right up to help create a care plan for that child that the pediatrician can actually carry out. And those are some of the things. I think the exciting new things that Andy and I are going to be working on is really a more intensive approach, which would allow us to begin to not only educate through our series, but really beginning to put those evidence-based guidelines into practice, to embed them into their practice so that they're up to date on the best treatment, on identification, and also long-term planning for those patients and families. And I think doing that's going to take several methods. So of course, computer-based, but we're also going to have this live video. But what's going to be really unique is having the opportunity for these pediatricians to actually shadow a pediatrician who is doing this, how they document, how billing is going to, hopefully, we're crossing our fingers on some work Andy's doing right now. But that they can spend the time they need with these patients. And as we all know, being sure that they feel like the plan is good and feeling like they understand it takes a little more time than, here's your antibiotic for this ear infection, we'll see you back in 3 days. It really is more intensive to be sure that they have that. And so, Andy, I'd love for you to share a little bit about how we've partnered together on this.
Yeah, I'd love to. And, I think, to me, a lot of the partnership centers on, let's just pretend like mental illnesses are like other illnesses. Well, let's pretend that they're actually in the body, and because for a long time we've set up our system, we talk about mental illnesses and physical illnesses. And I'm pretty sure my brain is physical. I mean, as far as I can tell, I can't actually see it, but I'm pretty sure it's physical. And I think, just to use my own life as an example, like I have 2 illnesses I've struggled with in my life. One of them is I have a family history of heart disease. So my grandpa, they found his heart disease when he had a heart attack in 1976, and they resuscitated him, and then they put him on egg beaters. For me, they detected mine when I was 35, and they've been haranguing me for 2 decades about my cholesterol and exercise and all that, and it's kept me ahead of things. And I've never seen I didn't see a cardiologist for 15 years. I only went to them because I was complaining about a medication once. But anyway, so that's how that's been treated. Whereas my anxiety that I've also had my entire life, that my mom wrote about in my baby book, and I think she wrote it down because she thought it was cool. I used the word anxiety when I was 3. That was not treated till I was 26 years old, until I was in graduate school and went and saw therapy. So I waited 2 decades. Fortunately, my mom got some self-help books and I think was in a good position. So, I mean, we basically just have to treat this like we do anything else. And it's hard because it's a pediatric illness. We don't want to think of our children as being anxious, as being depressed, as a risk for suicide. But if we don't, then we're going to put them at greater risk. And I think, so that whole point of what you were saying earlier, Madhukar, what do we do? I have so many people say to me, well, my child is talking about suicide. What should I do? And I'm like, go to the doctor, call your doctor. And I think, and a lot of times if people aren't sure, I said, well, what would you do if they had a large growth on their arm? Like, would you just hope it went away and kind of think it was okay? Or would you, if something different changed on another part of the body, would we do it? So that's why this pediatric piece, Julie, that we have the partnership on is so exciting, because we're basically bringing to our leading pediatricians through your health system, through our partners at UT Southwestern. And I think there's sort of like 3 groups of pediatricians. There's the pediatricians who know right now that they're treating these illnesses and embrace that. And I think a lot of those are in your system, and they're leaning forward into that, and they're learning. And I'm excited about the work we're doing, because we're going to be able to take those folks and help them, give them the tools to even be more empowered and to really put North Texas as one of the best places to raise a child, because our pediatricians are going to be there when our children have these inevitable concerns. Then I think there's the other pediatricians. There's so many pediatricians, family practice docs, that don't have the infrastructure that Children's does. Or then there's some who, don't really understand what to do. So that's why the infrastructure that UT Southwestern and Children's play a core role in here in North Texas, any pediatric provider can call and get a real-time consultation. So if you're a parent or a loved one of a child with a mental health concern, take them to your family doctor. And if they don't act in a way that makes you happy, say, hey, I'm pretty sure there's this thing that the state has, and I know Children's and UT Southwestern, and you need to ask and push them to do it. Push them just like you would for any other thing, and they will. They'll find the resources, and the help is there. And we can't, just like any illness, we can't cure everybody. There are going to be some tragedies, but the vast majority we can help. Paducah, you were going to?
One thing I'd very quickly add, Andy, to your point is that if pediatricians don't feel like they don't have the tools, once they start doing it in 2, 3, 4 months, they are actually go up and running. And so it is very similar to what happened with other medical illnesses, where the pediatricians started treating, and then they are very successful at it. So our task is to cross this threshold, and we are beginning to do it, but more needs to be done.
So Andy, let's come back to that for 1 second though. Is it fair to say that if I'm a pediatrician out in the community, it's likely possible and even understandable that I might say, hey, I was never trained in psychiatry, and I'm afraid that if I start going down this road with my patients, I'm going to open up a Pandora's box that I'm not equipped to know how to deal with, and I don't know how to get paid for providing any kind of therapeutic care to deal with mental health needs of my patients. And so I can't afford to go down that road. I don't feel equipped to go down that road. I'm not your guy. I'm not your woman. I'm not the person to do that in my regular pediatrician practice. Is that fair? And what do we do to assuage those concerns then that pediatricians may have?
Well, so what I do when they tell me that is I look them deeply into the eyes, and I say, I know you weren't trained, and I know you probably aren't getting paid, but I also know that you're doing this now. Half of the interventions that are provided right now, you are doing. So then you don't have a choice, because these are there's 100,000, actually there's 180,000 children in Dallas County who struggle with mental illness. Most of them, almost 3/4 of them are mild to moderate cases, most of which can be adequately treated in a primary care practice with the right supports. So then I thank them. I say, thank you. And then I say, let's talk about how you can do a better job there. And I point them to Children's. I point them to the Child Psychiatry Access Network, CPAN, which is this statewide resource that can help them. And then I tell them, we're working really hard on getting you paid. And in 2017, the Medicare program added payments in primary care. In 2019, almost every commercial payer, Blue Cross Blue Shield, that's my insurer, they pay for this. The biggest gap has been the Medicaid program, because a lot of children in Texas live in poverty. And so the Medicaid program is not paid, but we're really excited because I think because of just sort of this awareness we have on COVID, but also because our legislature has been leading on mental health the last several sessions. The Texas Senate last week unanimously voted to add payments for these interventions in primary care. Dr. Bonin in the House, head of the Appropriations Committee, is the sponsor of the House companion to this. The governor has been very clear that he cares about this and is a top priority. So, it is a legislature. we don't. There are things that can happen, and there's a lot of other things going on around, like ERCOT and whatnot. But we're very hopeful that this will get through. And so I really am just encouraging them to start billing and work with your office, work with your health system, start billing on the commercial side because it's covered. And what that allows you to do is allows them to hire that, like what Julie was describing, that care manager. So they have somebody in their practice to help them with non-medical interventions, like cognitive behavioral interventions, with family support, helping mom and dad, grandma, whoever's raising that child, to be empowered to do their part, because it's hard. It's sad to have I have young children, family members who struggle with depression, that's not easy to go talk to a child in your family and see their hearts weighed down, and you have to be there for them, and you need supports too. So so that's why I tell them, Brad, you're doing it anyway, but let's try to get you paid. That's kind of, and try to get you some help.
And I just want to echo, Andy, on that. Our legislature has been historically so supportive of telemedicine. And so we have had such great strides. And so even through the pandemic, we were already strides ahead. And so I think that's great. And I think something that you said was so important, the family piece. One of the things that I think Children's prides itself on in our integrated behavioral health programs, as well as our school-based programs, is the family in dealing with how to, we get asked all the time, so my child has this, but how do I discipline differently? How do I do this? It really is more, when you talk about it in pediatrics, it's more about not just the child, but it's the child and the family. And so I think it's important for our families listening today is it will take more than just the child, and sometimes simple medications or therapies or different ways. Every child's unique, every family's unique. And I think ensuring that we are providing our pediatricians with those additional resources is key to why we're going to be a difference here in Texas. I think we are going to truly move the needle in this unique opportunity.
But I think, Julie, the other thing is we have to demystify the problem. The question you raised, what a mother or grandmother is worrying about how to deal with the child, is very similar to the 15-year-old who got a little bit of a concussion, and now the mother is worrying, should I let her play? Should I let her go out with this? Should I let her go on a bike? So this kind of parental fear for our kids is normal. And I think we have to demystify. This is like any other medical issue. And they need education, they need tools, and they need support from the pediatricians and the mental health providers.
But can I just add, that is so important because it gives people hope. It's like, you can get through this. Look, and I think that hope is really, because a lot of times too, the stigma, if we don't talk about it, if we don't reach out, then we isolate, then we overprotect, we don't help that child, because it's not just treating the illness. They have to grow up. They do have to go to school. I'll tell sometimes people I'm training, I'll say, well, if they sprain their arm, you might let them kind of take a little bit of time setting the table or other household duties, but you're not going to totally remove all household duties. You're going to try to figure out how can we accommodate that, because you still have to learn and grow up. You still have to go to school. You got to do all these other things. And that's really hard to do, especially with depression. And so that's why you need, but the hope that this demystification, I think, is a huge, huge help.
I just got a call from a mother whose child got to Duke and has some mild depression. I talked to the psychiatrist and everything is working well. And yet the mother is asking me, should I pull her back to Dallas? And I said, would you, if they had diagnosed asthma in her, would you say, no, don't go to school, come home? Same thing. I think that we have to think of these things as like we do with other medical issues.
So help us understand too the benefits of early intervention. You've talked a lot about how early intervention can be great, and or the therapy and support that a pediatrician can provide may be very effective in dealing with low to moderate levels of anxiety, low to moderate levels of depression. A small number of kids that are going to have very serious issues that may escalate well beyond that. Do they need to start at a different point? Can everyone benefit from early intervention? How do you sort through that part of the spectrum, Dr. Trivedi?
So first and foremost, early intervention has huge benefits. I mean, I'm going to use Andy because he revealed his story. His outcome should be seen as lucky. If he had been treated, then he wouldn't have had those 15 years of having to suffer through it. Fortunately, it didn't really matter in the long run, but still. So first, the interventions are easier, the outcomes are better, and your life trajectory is much better. Secondly, the question so everybody should be screened and first started in pediatric family practice before you need a specialist, with some exceptions, because even for those who are very severe, the primary care provider or the pediatrician can do the screening and recognize that this one is not within my scope. It may be somebody who needs to go to psychiatry much faster. But still, that process can start in pediatric practice and family practice or in schools. Doesn't have to be where you wait for 6 months to find somebody. Yeah,
Yeah, I love how it's lots of people that we've begun to train. I even think about our Children's Health Andrews Institute. Many of our adolescent boys are reluctant or don't go to the pediatrician, and that's just historical. They get a physical, it's either in a mass physical or their mom takes them to the local urgent care. And so we have encompassed not only the school health nurse, but the coaches, and how to recognize, and the coaches are truly the relationship that many of our athletes have. And so again, I think as we begin to think about how you talk about this, we talk about it with everyone. We give everyone the tool to say, hey, something has changed. I want to be sure mom, dad knows that this might need to be addressed. We should get a healthcare professional going. And so again, super excited that we've been able to do this work, and we have obviously a lot more to go, but we're on our way.
I think a good analogy on that is, the schools as partners on allergies. I mean, what if children have food allergies? What if the parents had to but they used to have to fend for that on themselves. Now schools have taken that on. And we don't want schools to be treating illness. They're there to provide education, but they're a great place to detect illness and to help support families to find a place for help. And that's why the telehealth, I'm just so excited about it. Jill, I'm glad you added, by the way, if any of you care about the legislature and getting that process, tell them to keep all the telehealth stuff in place. Can you imagine, Julie, like a year ago before COVID, and this is probably the only good thing that came out of COVID, was telehealth access. I mean, we were preaching it was like to deaf ears. They're like, oh yeah, someday we'll do this. And now everybody has switched to telehealth, and most of our schools now have linkages there. So, and this works really well by telehealth. I mean, we're doing this by telehealth. I feel very connected to all three of you. I even revealed details about my life to you earlier. And Maduka, I would have had probably more of an active dating life in high school, for sure. So there would have been things that would have been easier with the anxiety. But anyway, so I mean, I think that it does take that entire community perspective, and then it makes it easier. Someone in my church, the child has, childhood cancer, some other thing, the church is going to marshal around that family, bring casseroles. If a child is depressed, usually the church doesn't know. And so you lose that support, you lose that help, and we want that help for our children.
If we can leave with one message, I would say the community really needs to get engaged and get involved and demand it. That teacher in class, if a 16-year-old is walking into the classroom and is limping, will not hesitate a second to ask the child at the end of the class, is something wrong with your foot? But if they see behavior change, there is not the kind of nomenclature, the education, the vocabulary, and that is what we need to change.
Okay, I know, but people worry they're going to make it worse, right? Isn't that what you hear? Will I make it worse? It's like, here's the thing. No, you will not. You will make it worse if you don't talk about it.
Since we are self-revealing, I'm the father of 2 kids, and people ask me all the time, if you ask your child about suicide, will they get that thought from you? I tell them, my 2 boys, I wish that every time I told them what to do, they imbibed what I said. They don't. This is their own ideas. So no, you will never put an idea of depression or suicide in your child if you ask them.
So when we talk about a specific tool or program like telehealth and virtual health tools, it's a phrase or a general kind of category that we've heard talked about a lot, especially over this last year during the pandemic. To your point, Andy, and access to telehealth and telemedicine programs has increased. But I still think that's kind of a little bit of a gray box to families to understand quite what that means. What is telebehavioral health? How are you going to help my child deal with a mental health or behavioral issue through an iPad? I don't know how that would work. Julie, talk us through a little bit about what a telehealth program actually means.
Yeah, and I'll be excited. I've preached this for a while. It's just healthcare. We're just accessing it in a different way. And to be honest, historically, adolescents and teens prefer this method. As many of our parents know, they much prefer to watch a YouTuber play the game today than they do play the game themselves. And so I think what is exciting is that we have allowed an access point for teachers and counselors that, again, always get parental consent, but allows them to come to a place to talk and say, hey, here's how I'm feeling. Here's what's going on with me. And our behavioral health counselor then takes them through a series of 6 or 7 sessions where they're able to move them through and give them guidance and support and resources and tools. And when I say resources and tools, it's many times education about self-talk. It's about how to deal with your emotions. We have a lot of kids, and if you have a high schooler right now, STAR testing's coming up. There's college admissions. The bar has been moved extremely high in terms of the level of complexity and the level of, it's hard. And these kids are striving for the top of the top, and they become anxious, anxiety, depressed. It is just a plethora. And now doing all that virtually has just been incredibly hard. And so what that allows us to do is connect with that patient or family. We stay connected. We make sure that if they go to a community provider, that provider is working for them. It doesn't, just like if you go to an orthopedist and you don't quite like what they're telling you about the process to fix it, you can go to someone else. And I think that's, again, what Children's is really allowing them to do, is giving them tools and resources. And when and if they need a different type of care, we're ensuring they get to the right one for them. And it's been extremely exciting. We just rolled out to our 9th county last week, and the school the very next day had a child they had been trying to figure out what they could do, and immediately got that child a consult. Very simple. And what I am recognizing, that the need continues to move past just what I would say junior high, senior high. We're getting requests for 5th grade and 6th grade. So again, we do always look at what's the best appropriate way for this child. And for some children, obviously very young children, this may not be the best way. And so again, being the resource in that school, we try to move that family to the local best place for them.
And depression and anxiety treatment, especially in kids and teens, does not have to always include medications. In fact, most often it may just need psychotherapy, which is what teletherapy, telebehavioral activation, is ideally suited for. So there are components of the treatment which does not require medications, which can very easily be done.
Yeah, and I think that's important to keep in mind. I think what I like to think is parents should be offered the full range of choices. And I think so. And I think sometimes we do give medication a bad name. I mean, and no one wants to take medication. Like, I fight my doctor about my cholesterol medication. But I think that we want to give parents and caregivers choices. And I think the telehealth gives more choices, and it's a wonderful thing. And I think, Julie, I was really liked how you described that interaction with the specialist. And I want to revise a little bit my answer earlier, Brent, about what I tell pediatricians. I mean, that's what I tell my friends and the ones I'm trying to convince. But what I tell them in the community is, like, this is standard of practice, folks. What other illness would you ask me about whether you think you should do anything about it? I mean, you're going to not deal with cancer because that's hard? I mean, like, you're here and the standard of care. So if you go to your pediatrician, if you go to your doctor and you have a concern and you don't get a good answer, you need to push them or maybe go to someone else, because this is the standard of care now. And there's no excuse anymore. And we need to insist on that as community leaders and most importantly, as parents and as friends of parents, because that's a hard thing to do sometimes. We have to do it for other illnesses. And so we can do it for this illness.
So it will not surprise the three of you that there are a number of questions that are coming in to the text line as you've been talking. So I want to start bringing some of these into the conversation. And on that very point, Andy, someone has asked about kids who are facing mental health conditions that are very complicated and maybe require multiple medications. And that involves a lot of integrated coordination and some complex assessment about what the right approach, what the right therapeutic path might be. And, my neighborhood pediatrician is not going to be really equipped to know how to deal with that. Are you telling me all those kids have to go through their neighborhood pediatrician to start with? How does that factor in?
Well, I think part of it is we're not detecting these illnesses early right now. So we're detecting these illnesses later. So there's a lot of illnesses we're going to detect, and we detect cancer when it's at a very advanced stage. So we absolutely need specialists, and we need to work on getting that access, which fortunately telehealth helps with. So we have much better access to those specialists now. And the networks we've been building, that UT Southwestern with the other medical schools have been building, Children's with its fellow partners, that there's now larger networks. And so it's easier to find that, though it's still very hard. I don't want to say it's easy, but there's not enough of any kind of doctor. It's hard to find good back care. I mean, we need to push and help and build that up. That being said, I do think it's important to keep in mind that big illnesses start out as little illnesses. And schizophrenia, very severe things. There's a lot of research that shows there's anxious behavior, other behavior in childhood much earlier than the emergence of the psychotic symptoms. So I think that it's both, Brent. We need to have that full continuum that Julie described, where if we don't find the illness until it's later, which a lot of times we won't, or if there's a rapid onset, which I mean, there can be around life events, for example, traumas, we need to get to a place where we can get severe help. But we should be casting the net wide to reach folks early, because even the children who have the most reactions to trauma, for example, one of the biggest predictors of that is things that happened earlier that maybe weren't quite as triggering, weren't quite as overwhelming, losses of family members that maybe they dealt well with, but now you're pre-positioned to have a harder reaction. So it's really both. We have to do both of those things, and that's why the continuum described.
We are getting into a false choice in health care, because it's not the pediatrician or specialist. It's kind of thinking about both. That person who is on 4 or 3 medications, the child or an adult, doesn't end up first day with the severity of the illness where you need 4. What ends up happening is it ended up being not attended to before, is why now we are at 3 and 4. So that may need a specialist, and you can do that faster.
So you had to know that this question would come up. I'm sure that all of you have been asked this multiple times. Speak a little bit to the influence of social media in the world and its effect on kids. Obviously, kids are one of the biggest groups of consumers, although, I mean, adults these days too are huge consumers, obviously, of social media. Everybody's got a question or concern about what that's really doing inside our heads. What is its impact on kids?
Julie, you want to take it? But one thing I'll say, one important thing to think about, it does have an effect, and we have to monitor and guide and assist teens and young children, like we do with their diet, with their nutrition, with their exercise. We need to do it with social media. One message that I at least have taken from all this is most often their behavior is actually mirrored by us. So some of it we have to try to figure out how to work with our children also.
So I agree with that, but we've done a meta-analysis on this and looked at it pretty clearly. And I think the best way to think about it is it's just like any other part of life. I mean, it's part of this is like we're old and we need to complain about something. So, you know, my parents complain about rock music. We complain about screens. It's a neutral thing. It's something to be used for good or bad. And it's a compelling thing. So bad things that can happen is it can get in the way of other developmental tasks. It can get in the way of going outside and exercise. It can also enable developmental tasks like being able to be more social. I probably also would have dated more in high school if I could have done social media because there's less anxiety around that. But I think that the second thing is it also becomes a platform for bad things to happen. I mean, when I went to school, I mean, bullying was getting beat up, and that was a thing, and that still happens a little bit, but I think that there's been more awareness and reduction of that. But bullying ended when I left school. When I got home, I was not going to get bullied. Now that doesn't happen now because that screen's at 24/7. And Julie, you see that. I mean, go ahead.
Yeah, I think you both have hit it. There's good and bad. I think about how monitoring your children and it becomes more difficult. The kids are savvy. Who knew that calculator icon held 3 or 4 different social media apps you told them they shouldn't have. So first thing I can tell parents is get your kid's phone, go through it, look at all the things, monitor it. I do that often, and but it is a habitual thing. So I have a 19-year-old. We've all revealed something about ourselves, and I noticed at some point she was habitually Instagram, and it was constant in all her downtime. And we just had to have a really frank conversation about it, that what was so intent that she had to feel like she was missing out if she wasn't keeping up. And we took a break. And it was difficult for her. You've seen a smoker quit smoking. It is very similar when a 17-year-old is no longer Instagramming 18 hours a day, it felt like. And so I think that's piece. But I'll tell you what is exciting. And like you said, parents are now reaching out on Facebook, on mom groups, on social areas saying, my child needs help. Who can help me? It happened yesterday with a friend who has a 21-year-old who has inherited, she feels, her severe depression, and she couldn't get anyone to help him because he's 21. And so it was just this incredible opportunity. And so it was incredible to see, A, she felt comfortable putting it out there, and B, there was more than just me responding with, how can I help you? And so good social media use and bad social media use. And I think, like most things.
Fair enough. We are getting close to time here. And before we wrap up, I do think it'd be helpful to take a little bit of a peek into the future. Dr. Trivedi, you are doing some groundbreaking research right now that a lot of people are probably not aware of, looking at sort of the roots and underpinnings of mental health issues in kids that may be informed by just the way our genes work. Tell us a little bit about what, to me, actually sounded like science fiction. And I know today it is no longer science fiction. This is real. Tell us about what your research is showing about the genetic markers for mental illness in kids.
So I have to confess, most good, at least in my experience, most good research ideas are very simple. It dovetails with what Andy was saying, is we want to be able to identify as early as there are indications that there is a problem. So what we are working on are three major areas. One is looking at blood-based genetics, gene expression, things that change in the person, in the child, as soon as we can notice there are some signs, and find markers so that we can develop blood tests. These risk factors and early signs also ultimately, as Andy mentioned, lead to changes in the brain circuits, how brain functions. So if somebody, a teen with depression, gets a stimulus and starts ruminating about negative thoughts for 4 days, that is, their circuit is affected. So we are developing brain tests with EEG and MRI to try to do these tests so that when a 16-year-old comes in, you can do these tests and say, yes, your child has depression. And so that is what we are aiming. That's the research. And the third most important leg of that research is to then identify the right match for the treatment with the kinds of pathology you have. What we do with all medical illnesses, you have a bug, you give the antibiotic that matches with that bug. You have rheumatoid arthritis, you do the test and you give the treatment that works on that. And right now for depression, anxiety, what we do is we have a lot of very good treatments, but we don't have a way of matching Susie with the right antidepressant or the right anti-anxiety agent. And that will be done with these blood and brain tests. Those are the three main areas we are looking at. And the majority of our focus is in young people, because the problem with waiting until they are 40 and 50 is these circuits then start having significant effects on the brain, the way they think, the way they feel, and the way they relate to the rest of the world. So we need to do it fast. So that's the work of the center.
Well, that's amazing. I mean, we hear a lot of conversation about personalized medicine, and you tend to think about things like cancer and not necessarily mental illness. And it is pretty mind-blowing, actually, to think that we're on the cusp of understanding so much more about the genetic makeup and underpinnings of the way mental illnesses work, just like other kinds of physical illnesses.
I have to say, for the first time in 25 years, I am excited that it is within our grasp. We have actually published results from EEG studies where you can do a test that I can tell you with 3 times better certainty that Zoloft or antidepressant sertraline is going to work better than something else. So I think we are very much within grasp of being able to do that very, very shortly.
Amazing.
Brent, that's so exciting. Can I just add, like 7 years ago when we launched the Institute, we had our first meeting in Austin, and I had someone ask me, I said, where would my adolescent boy get the best treatment for his mental health conditions? And I had to say, unfortunately, not in your community. There's places you could get to outside of your community. Or there's a very good chance the best treatment in your community is actually the juvenile justice system, because they actually had some good stuff. And that's where we were 7 years ago. And now, and actually it's been a couple of years now, but now just in the last few years with the transformation and the leaning forward that Children's has done, the rapid, some of the research Dr. Trivedi is talking about, I could now say go to Children's Health. I mean, and it's not just go to Children's Health and I'm not just saying this because I like you guys. I mean, I would say positive things. I just wouldn't say this positive thing. I would say, I mean, it's a beacon. There's a place now for families to go. And you guys were doing treatment back then, but I think the capacities increased, the networking, the linkages, the leaning into the larger system. So many advances have been done that now I think we really are not just at the point where we can do personalized medicine increasingly, but where we can have an expectation for systemic intervention where we're screened in pediatric settings, but we also should expect that sort of specialty consult if we are looking at multiple medications. So it's exciting. I'm just so thankful that this has been, that y'all have developed this.
And I just want to say with Dr. Trivedi, the translational research, the connection with UT Southwest, we need to take that bench science, and we're able through our network now to get that at the bedside, the coach's side, the teacher's side. And so incredibly exciting.
Well, of course, Andy, we appreciate the plug for the resources available at Children's Health. And so many of the resources that we're going to directly provide are going to be for kids in that moment of crisis and or who have the highest level of need. Children's is not going to be necessarily the direct service provider for the largest number of kids that have mild to moderate levels of anxiety and depression. And so for that aspect of what we've been talking about, honestly, this collaboration with so many partners, including Meadows Mental Health Policy Institute, especially in working across a different sort of plan for the community and getting parents and kids access to what they need at the easiest entry point is going to make such an enormous difference. I'd be remiss if I didn't share today that there actually is a triple match right now for contributions to Children's Health that support the mental health needs of kids. You can go to give.childrens.com for more information on that. Triple match is always great to amplify any charitable gifts that people want to make to support addressing the mental health needs of kids. And this is a unique moment in that regard. But the three of you have covered a wide range of, again, really insightful and relevant information for parents and families to help better understand what to do in addressing the mental health needs of their kids, how to recognize that, and where to turn for help. And so we appreciate all the insights that you have shared. You saw flashed up on the screen a second ago a list of resources for those of you that want to dig a little bit deeper or need to turn to one of them for some additional help. We will put those up again on the screen and send out that information in an email that will be available to everyone that's participated on the call today. So please know that we will put that information into your hands as well. With that, we're going to wrap up today. Thank you so much, Julie Hall-Barrow, Andy Keller, Dr. Madhukar Trivedi. The three of you have opened our eyes to so much, and we're grateful for your expertise, for your time, for the generous way that you have shared with us today. And thank you to everyone for joining us for this virtual spotlight. We'll have another one coming up at the end of April. Stay tuned for more information about that. It will be on a different topic. But for now, we're grateful to each of our three experts today and to all of you for being with us on this program. Thanks very much.
Thank you very much.